We'll just start, Vipul bhai.
Should we start?
Yes. Dr. Arora, can we start?
Yes, we can. Yeah.
So, good evening, everyone. I am Dr. Yogesh Harwani, and on behalf of Ahmedabad Physician Association and Noble Gastro Hospital, I welcome you all to 7th Clinic of Advanced Gastro Summit. I thank Gujarat State Chapter of ASI, Gujarat State Surgeon Association, Association of Physicians of Gujarat and Ahmedabad, and Ahmedabad Surgeons Association and Gujarat State Family Physician Association who have contributed to this academic event. And today we have a very senior and respected national and international faculty with us, Dr. Anil Arora. He will be introduced by our today's chairperson, Dr. Tapan Shah, who is a physician at Ahmedabad. And we have our moderator, Dr. Vipul Shah. He is a senior adult infectious disease specialist. Definitely, hepatologists do manage patients with cirrhosis, with hepatitis B and C, but infectious disease physicians also have a role in this practice, and they too manage such patients. So today we are fortunate we have Dr. Vipul Shah. He is an infectious disease specialist, and he is also a very active member in Ahmedabad Medical Association. So I would like to request Dr. Vipul Shah to introduce our today's chairperson, Dr. Tapan Shah.
Very good evening to all of you who has joined this wonderful webinar. We know that the hepatitis B viral infection is a preventable disease, and those who unfortunate unvaccinated person when get infected with the hepatitis B virus, they may have either acute or chronic infection, and sometimes chronic infection may lead to the cirrhosis of liver and hepatocellular carcinoma. There are physicians comes in role when they are getting referred from their well-wishers, gynecologists, surgeons, general practitioners. When the hepatitis B surface antigen comes positive of patient, they have been referred to physician. How to evaluate, which are the various markers, how to treat it. So today we have a very senior Professor Dr. Anil Arora with us, who will guide us on management of hepatitis B in 2020. So before we start, I would like to introduce today's chairperson, Dr. Tapan Shah and Dr. Harsh Maniyar. Both are physician, practices at Sangeeni Hospital, Satellite, Ahmedabad. So please, Dr. Harsh or Dr. Tapan Bhai.
Good evening, everyone. Very warm welcome to this seminar. I'm privileged to introduce Dr. Arora sir, who is a chairperson of hepatology and gastroenterology and pancreaticobiliary sciences at Shri Gangaram Hospital, New Delhi. And we often go through his articles, and we have learned so many things from sir. Over to you, sir.
Thank you, Dr. Tapan. I am thankful and grateful to Dr. Yogesh and Dr. Vipul for having given me this opportunity, and especially the branch of API in Ahmedabad. The topic which has been allotted to me is viral hepatitis. How do we manage? How do we go about it? I did take the liberty of switching over from simple hepatitis B to a common variety of all types of viruses. So 20% of the time I will be devoting to non-B hepatitis, rest 80% will be devoted to hepatitis B virus infection. Are my slides visible? Can you hear my slides? Okay. So greeting from Sir Gangaram Hospital, where I am practicing as a gastroenterologist for almost 30 years now. Viral hepatitis by default is a systemic viral infection which is characterized by hepatic cell necrosis and inflammation. It has a classical, typical, and stereotypic picture, which is characterized by clinical, biochemical, and histopathological profile affecting hundreds of millions of the people all over the world, leading to considerable morbidity and mortality. In fact, till World War II, which started in 1942 and ended in 1945, there were only two types of viruses and two types of hepatitis which were known, hepatitis A and hepatitis B. So one which was transmitted by the fecal-oral route was referred to as infectious hepatitis, and the one which was transmitted by blood or the blood-borne products was referred to as serum hepatitis. Mind you, neither hepatitis A nor hepatitis B was discovered at the time of World War II. Hepatitis A was discovered in 1974, whereas hepatitis B was discovered in 1968. But thanks to large strides made by genetic engineering technology, molecular biology, and the basic biochemistry, today we have list of all viruses which are very well characterized. They go from hepatitis A, hepatitis B, C, D, E, F, G, TT, and Delta virus. And tomorrow, who knows, Dr. Yogesh may invite some another speaker after 5 years, and we may end up completing the list of all the alphabets of the English language, and we will have characterized all the viruses by then. Starting with the commonest virus which affects us on day-to-day basis is hepatitis A. It has a worldwide distribution, typically occurs in children, has a high familial aggregation and high attack rate, like what we are saying with the COVID-19 infection. Luckily for us, luckily for our patients, there are no animal or human reservoirs. That means nobody will have chronic hepatitis A. Either you have acute infection or you do not have an infection. There is nobody who has chronic hepatitis A. Classically, the disease spreads by the fecal-oral route. That means an infected person has to transmit the infection through the feces via the fecal-oral route to the another person. So it has to be a contaminated food or the water of an uninfected person, which has to by default come in contact with the fecal-oral contamination of the infected person. Mind you, only boiling kills the virus. Freezing and heating is not enough. If you think you yourself, your kids or your siblings are baking the pizza in the microwave or eating an ice cream, which they think it's frozen, is not going to kill the virus. If you want to get rid of hepatitis A, please boil the food. Typically, the incubation period is around 30 days. Luckily for us, again, luckily for our patients too, 80% of the time, this infection is asymptomatic, resulting only in minor illness. However, with increasing age, you are more likely to have symptoms related to viral hepatitis, and you are more likely to be jaundiced. That means if you are elderly, you are more likely to be jaundiced and have symptoms because of hepatitis A. Once you develop hepatitis A, which most of us tend to do in country like India, we tend to have lifelong immunity. Antibodies in the breast milk are protective. And hence, if you look at the graph of hepatitis A virus infection, it does not occur up to the age of 1 year. And as the age increases, see, our kids, our children in the poor socioeconomic countries, they come in contact with the contaminated food and water and they develop infection. In the first year, again, because of the protective antibodies in the milk, breast milk, you do not have infection in the infancy. So this is something which is important for us to understand, that depending upon what age do we have hepatitis E, our incidence of jaundice, need for hospitalization, and the mortality is quite variable. Look at the typical setting. In India, we tend to develop hepatitis A by the age of 15 years. Most of us do not have jaundice, and we hardly ever require hospitalization. Death rate is pretty low. But as the age is increasing, we are more likely to get hospitalized. Say one of us at the age of say 40, 50 years, if we develop hepatitis A, we have a 40% chance of need for hospitalization, and the mortality or death occurring as a cause of hepatitis A is to the tune of 2%. This is almost 200 times more than 0.17% mortality which tends to occur in childhood. So what is the lesson? Lesson, ladies and gentlemen, is if you have been given the choice of having hepatitis A, please have it in the childhood. Diagnosis of hepatitis A is typically made by demonstration of IgM type of anti-hepatitis A virus antibody, even though this diagnosis of hepatitis A was made in the stools by the scientists when they looked at the virus particles in the stool. And once the infection with acute setting settles in, then after 3 to 5 months, you tend to develop this IgG type of antibodies, which are a proof, which are a postcard, and which are a passport for you to know that you have had infection in the past. How do we prevent hepatitis A? We need to drink the chlorinated water. Most important is you have to properly dispose of the human excreta, because this is the only source of transmission of hepatitis A is the infected guys, because there are no carriers. And this infected person, if disposes of his human excreta properly, I'm sure there is not going to be any hepatitis A. You have to scrutinize the food handlers, and in the siblings, you can even think of giving immune serum globulin for control of the infection. A vaccine is very recently available for hepatitis A, not recently available for last many years. There are two forms of vaccine which are available, Haverix A and Haverix A 720 for the children up to the age of 18 years, and you have Haverix 1440 units for adults in the recommended doses as per the manufacturer's advice. Again, at the same time, we have an infection which can be prevented in addition to prevention of hepatitis B. And we have this twinic vaccine, which has a combination of hepatitis A and B vaccine. This is called twinic vaccine. So you can give it in 3 recommended doses at an interval of 0, 1, and 6 months. And you can give this injection as per the recommendation. If you are adult, you need to have this twinirix adult, and as a child below the age of 15 years, you need twinirix junior. So advantage of this is that you can give the same vaccine at the same time, same needle, same point, same visit. So that saves the patient traveling back to you again for vaccination. The second commonest infection which is transmitted by the fecal-oral route is hepatitis E. This typically occurs in Indian scenarios and in the underdeveloped countries, and it is the cause of almost all epidemics which have been reported till date. All epidemics of waterborne infection till date reported anywhere in the world are related to hepatitis E. This typically occurs in settings of poor socioeconomic status in countries like ours, when there is a flooding and recession of the flood waters, there is a confluence of the drinking water resources with the sewage disposal plants. That means the pipe which is carrying out your sewage excreta gets intermingled and gets confluent with the pipe which is supplying you the water. So there is a large amount of intermixing of the drinking water supply with the human excreta, leading to supply of contaminated water to large number of the areas which are supplied by that confluent pipes. So you can have mohallas, you can have district, you can have streets, you can have blocks which can be readily infected with hepatitis E. Few things to be remembered about hepatitis E. Typically occurs again in young and middle-aged people, has an extremely high mortality of 20%, especially in the 3rd trimester of the pregnancy. Imagine a young girl getting pregnant, goes for a honeymoon, comes back, conceives, and once she gets infected with hepatitis E, you have a 1/5 chance of losing her. Again, like in hepatitis A, there is no chronicity of the virus, and the virus, once it occurs, gets spontaneously cleared in most of the patients. Typically, the diagnosis is made by demonstration of IgM type of anti-hepatitis E virus antibody in the blood. Coming on to the blood-borne infection, of which hepatitis C and hepatitis B are extremely important. In fact, when hepatitis B was discovered way back in 1968 by Dr. Blumgart, who was subsequently awarded the Nobel Prize, we had something called post-transfusion hepatitis. People who would have done their MDs and DMs in late 80s, early 90s would remember an entity called post-transfusion hepatitis. That means even if you were screening the blood for hepatitis B, a lot of patients will tend to develop hepatitis, which was referred to as a post-transfusion hepatitis. At that time, we knew it was hepatitis B. So it was neither A nor B. So it was called non-A, non-B hepatitis. And thanks to the 3 scientists who, after a long vigilant and diligent research, discovered this virus called hepatitis C virus in 1989 in patients who were being infected with viral infection after transfusion. This was called post-transfusion hepatitis C. And I'm sure all of you would agree that only about 1 month back, we had these three scientists, Dr. Harvey Altered, Dr. Nile, and Dr. McCotton, who got the Nobel Prize for discovering this virus, which has changed the scenario of hepatitis C in the world. Earlier, we used to say, oh, hepatitis C has no meaning. It was referred to as a non-B hepatitis. And subsequently, by the time hepatitis C was discovered, we knew that it was one of the major problems, which was prevalent not only in India, but also in the most of the parts of the world. There were areas in India, even today, if you look at India, we have belts like in Punjab, like in Rudrapur, like in areas of the Meerut, where 20% of the population suffers from hepatitis C. In India, we have an average of about 1% prevalence of hepatitis C, and we already have around 17 million cases of hepatitis C in India alone. Hepatitis C and D, the basic hepatitis B and C, the basic difference is that hepatitis C is typically mild. Usually it is anecdotic. Most of the time it leads to chronicity. Look at these differences from the fecal-orally transmitted A and E, which are mostly symptomatic, which are mostly icteric and do not lead to chronicity. 20% of all those with hepatitis C will develop cirrhosis of the liver, and those with cirrhosis of the liver have a propensity to develop hepatocellular carcinoma at a menacingly high rate of 5%, 3 to 5% per year annually for development of hepatocellular carcinoma. Hepatitis C is diagnosed initially by screening with IgG type of anti-hepatitis C antibody and further confirmation by HCV RNA, which can be done easily. Now, all those who have hepatitis C, 20% of the patient will have spontaneous recovery, 80% will develop chronic hepatitis. Of those with chronic hepatitis, 20% will develop cirrhosis of the liver, and those with cirrhosis of the liver are likely to have all complications of cirrhosis like GI bleeding, hepatic insufficiency, or development of hepatocellular carcinoma. This is the story of a young boy who died at the age of 20 years. At autopsy, he was found to have a macronodular liver and a huge hepatocellular carcinoma. This young boy was given blood transfusion in 1980s for a congenital heart disease, and 20 years later, this guy dies of hepatocellular carcinoma occurring because of hepatitis C. Till recently, till about 4 years back, the treatment of hepatitis C was very arduous, very cumbersome, and totally nonchalant. But thanks to discovery of large number of new drugs, and this is how we used to treat in our days of MD and DM for hepatitis C. So the response rate with interferon, with ribavirin was dismal. In spite of 1 year therapy with potentially serious side effects, we will have a response rate of only 40 to 60%. But thanks to this development of new drugs called direct-acting antivirals against hepatitis C, we have now achieved almost a cure of the virus hepatitis C. Look at the way hepatitis C is treated. Now, with almost 3 months therapy of hepatitis C, we have almost cure of the virus. Knowing these facts, I'm sure the Nobel Prize Committee, which was looking at the Nobel Prize for Science, very aptly honored 3 physicians and microbiologists who looked at the diagnosis and management of hepatitis C, and we're really thankful to them. Finally, coming to hepatitis B, for which the talk was meant today, and as I said, I'll be spending most of my time trying to tell you what hepatitis B is and how do we handle it. Hepatitis B, like hepatitis C, has a worldwide distribution. Unlike hepatitis A and E, which are waterborne, you have a lot of patients who are chronic carriers. They can simply be carrying the virus in the blood without being symptomatic, or they may be suffering from chronic liver disease like cirrhosis of the liver. Overall, in India, we have a positivity rate up to the tune of about 2.5%. So we have 40 million carriers of hepatitis B in India alone. India has a dubious distinction of being the second major country in the world harboring hepatitis B virus infection, and we may even surpass our old enemy China, and we may end up having more cases by 2050 than China of hepatitis B if we do not take care of our infrastructure and health. Hepatitis B has a worldwide distribution, as I said. There are countries like Sub-Saharan Africa and part of the East Asia, which have a high prevalence of hepatitis B. Any country which has a prevalence of more than 8% of the population will have high prevalence zone of hepatitis B. Look at the developed world, most of the US, Western Europe, Australia, and the developed part of the South Africa. They have a very low incidence of hepatitis B, whereas countries like ours, Russia, China will have intermediate prevalence of hepatitis B. The way, how does hepatitis B spreads? You need to have, unlike hepatitis A and E, where the only source is contaminated stool which is infecting the water and the eatables. Whereas in hepatitis B, you have plenty of explanations for the spread of the disease. It has to be a percutaneous spread. That means the blood or secretions of an infected individual have to come in contact with either the mucous membrane or they have to pierce the defenses of the body to produce infection. That can occur either with percutaneous spread like blood or the blood-borne products. When we were doing our residency, we used to get commercial blood bank. That means you pay 400 rupees and you get a bottle of blood from the commercial blood bank. But thanks to realization by the Indian scientists and the Indian government, I am happy to announce that commercial blood banks are blocked, are banned, and nobody is allowed to use purchased blood. Nobody is allowed to sell blood, and only blood you can acquire in Indian scenario is the blood which has to come from the voluntary donation. Razors, shaving razors which are possibly used commonly amongst brothers and the male members in the same family, acupuncture needle and ear piercing. These are the potential sources of spread of the infection from one infected person to another. Let me tell you that even 0.07 ml of the blood, let me repeat it, 0.07 ml of the blood may remain dry onto a blade or a razor or a acupuncture needle or an ear piercing needle and can be the source of infection subsequently for the person who is using it with the next 7 days. You can see how the infection spreads within the family in different individuals. Needles, tattooing needles is becoming the fashion of the day. People will look at our beautiful film stars, Hollywood stars and Bollywood stars, and they'll keep copying their tattooing. And once you get tattooing, you are not sure whether you are using a disposable needle, and that may be the source of infection. And then you have unfortunate lot of people who are intravenous drug abusers or hemodialysis. They are more likely to have hepatitis B virus infection. Then there is a sexual contact. Infected male can spread to a female partner and vice versa. There may be a transmission of the infection during perinatal period from an infected mother to the innocent newborn baby. Luckily, breast milk in hepatitis B is safe to be used. So what happens to hepatitis B? Why is it that we are spending almost 4/5 of our time to hepatitis B, forgetting about other viruses like A, C, D, etc.? That is because once the virus enters into the cells, there is a disintegration of the virus, and part of the genomic material called recombinant RNA gets into the nucleus, producing something called covalently closed circular DNA. Now, this is the culprit. Once it is gone, it assumes a permanent residence within the hepatocytes and does not come out, thereby giving a factory an ongoing production of millions of the antigens and the various type of mRNAs, which are subsequently coded and recoded and assembled into different components, which produce new virion. Up to 10 raised to the power 5 million, up to 10 raised to the power 5 copies of the viruses are produced each day in the human body by this virus. Because there is an unrelenting factory which is stable and which cannot be taken care of by the immune system within the body. So that is the CCC DNA, which is the culprit of continuing presence of infection within the hepatocytes compared to other viruses like hepatitis A, E, or hepatitis C. This is something which I think I like to spend a minute on this to explain to you what this chart means. I think this is very important for all of us as clinicians to understand. Now, as I said, 80% of those with hepatitis C will develop chronic infection. Luckily for hepatitis B, only 5% of adults will develop chronic infection, and 95% of adults like us who develop hepatitis B will have spontaneous clearance of the virus. But look at the way the hepatitis B chronicity occurs as per the age of acquisition of the infection. Now, if you are adult, as I showed you, If you get hepatitis B today, say because of the accidental prick or a mismatched transfusion or because of some reason when hepatitis B could not be tested, you will have a spontaneous clearance of the virus over the next 6 months, 95% of the time. Only 5% of us will continue to have the virus in the blood. So a chronic infection is somebody who is having virus infection in the body for at least 6 months. But look at this young baby who is born at birth. If the pediatrician or the obstetrician is careless, they do not look after the mother, they do not screen for the mother, so hepatitis B status, or if the pediatrician does not take care of the baby in terms of giving vaccination to the baby at birth, as well as hyperimmune serum globulin, this baby is destined to have 90% carrier state. So for no fault of this baby, who's innocent, cute baby to be born yet. So if some of our pediatrician and gynecologists have to be absolutely careful, and all of us as clinicians should know that all pregnant women should be screened for hepatitis B. And the moment she's B positive, I'll give you the reason we need to treat them if they are in that range for treatment. And we must make all the efforts to prevent this infection going into the young baby which is yet to be born. Because if we do not take care of this infection at birth, because of the perinatal transmission, this baby is going to live lifelong with this infection. And similarly, if the infection tends to occur at a younger age, you're more likely to have infection. See, at the age of 4 years, you have a 25% chance of becoming carrier. At the age of, say, adulthood, you have only 5% chance of becoming carrier. So what is the lesson? Lesson again, ladies and gentlemen, is if you are given the choice of having hepatitis B, please have it in adulthood. I had already told you, if you are given a choice to have hepatitis A, have it in the childhood. If you are given the choice of having hepatitis B, please have it in the adulthood. Typically, the jaundice will settle in most of the patient, as I said, in immunocompetent adults over the next 6 weeks to 6 months in about 95% of the patients. And during infection, the virus is known to be secreted in every body fluid: serum, CSF, breast milk, ascitic fluid, gastric fluid, pleural fluid, urine, seminal fluid, and saliva. As I said, luckily for us, 1% of the patients go into acute liver failure, and there is a subclinical recovery in majority of the patient. And acute hepatitis, most of us would recover. 5% will develop chronic infection, and those with chronic infection will have the same fate as what happened in hepatitis B, that you are likely to develop cirrhosis of the liver and hepatocellular carcinoma. So how do we know what has happened to our hepatitis B once we have acquired it acutely? You look for anti-HBs antibody. So once it is present, that means you cannot have infection again, and you got the cure from the virus. Whereas if the patient is a healthy young baby who's immunosuppressed, does not have good immunity to get rid of the virus, so this baby will become a lifelong carrier. The moment you are a carrier of hepatitis B, mind you, you have a 200 times more risk of developing liver cancer than a person who does not carry the virus. And then it is extremely important that we must make all efforts to prevent the young babies. Another story of a person, a 30-year-old guy who died of road traffic accident. And autopsy was found to have a macronodular liver and a large hepatocellular carcinoma. And he had upper GI bleeding, which killed him because he could not reach the hospital for the proper care. And at autopsy was found to have a macronodular cirrhosis of the liver. And this unfortunate guy had received blood transfusion 4 unit during his surgery for hernia almost 20 years back. So this is the sequelae of hepatitis B, which was left untreated. Typically, the symptoms of viral hepatitis, whether it is A, B, C, D, E, will be same. Patient will have anorexia, nausea, vomiting. Relatives will tell you that you will have high colored urine, or your eyes look yellow. So you have to bank upon the blood investigation to know the type of hepatitis. Typically, some of us have a habit of just getting a serum bilirubin done to diagnose viral hepatitis. Mind you, if you want to diagnose hepatitis, you need to have AST/ALT. Without that, you cannot make a diagnosis of viral hepatitis. So please, just by doing serum bilirubin, you cannot make a diagnosis of viral hepatitis. You need to have AST/ALT in every patient, because hyperbilirubinemia can occur in hemolytic anemia. It can occur as a part of congenital syndrome. It can occur because of mismatched transfusion. Whereas if you have a SGOT-PT of more than 1,000, there is only one diagnosis, that is hepatitis, and you have to just look at the etiology. prothrombin time is something which is important, at least in the acute phase. In patient with acute viral hepatitis, it gives you immense information whether you have raised prothrombin time or not. A raised prothrombin time in a patient who has acute viral hepatitis would mean an ongoing hepatic necrosis. Now, since we have very well established liver transplantation program in India, so patient today may be able to afford liver transplantation. And there are some symptoms which tell us which patients are more likely to go into liver failure. So any patient who has a persistent anorexia, any patient who does not have a palpable liver, any patient who has a persistent vomiting and aversion to eating, these are the signs of ongoing active necrosis of hepatocytes within the liver in the acute phase. And you can further document it by doing an objective way of assessing the LFT by looking at the prothrombin time. So once the patient comes to you in the acute phase, or if the patient is incidentally detected during, say, blood examination, during executive health checkup, or when the patient applies for a visa to a Middle East country and he says he comes back to you that is HBsAg positive and visa has been rejected. So what do? We look for two types of tests, whether the patient has multiplying virus or the patient does not have replicative status. If the patient has anti-HBsAg positive, that means this patient has a protective disease. You don't need any treatment. If the patient has IgM anti-core antibody, that means this patient had recent infection. Anybody who has E antigen positivity and DNA replicative status, that means this patient is likely to have replicative virus and is likely to be infectious to others. So this is again coming back to the role of physicians, gastroenterologist, pediatrician, as well as the obstetrician to know the maternal fetal unit. The infection from the pregnant mother to the baby occurs mostly during delivery when there is a large amount of the intermixing of the fetal and the maternal blood. So any intervention which is to be done during pregnancy can lead to more spread of the infection to the baby. So we recommend all pregnant women should be screened for hepatitis B, and those who are positive for hepatitis B, if they have a high viral load, should be given antiviral treatment, which I'll be coming to you shortly. And the pediatrician has to be ready both with hepatitis B serum immunoglobulin and HPV vaccination to prevent this baby who gets infected right at birth. So whether a pediatric obstetrician needs to do a cesarean or a normal delivery, that should be left to the obstetrical factors and the fetal factors. And I think as gastroenterologists and hepatologists, we cannot advise them which type of delivery they should conduct, knowing very well that we may have to give antiviral therapy during some stage of pregnancy. Coming on to the recent updates in 2020 in hepatitis B, which Dr. Yogesh had asked me to really cover up. Four things are important: vaccination status, ALT, the definition, what are the preferred initial therapies for patients who have chronic hepatitis B virus infection. Mind you, all viral therapies which we are talking today have to be given only to the patients who have chronic infection. That means patients who are carrying the virus in the blood for at least 6 months. And then you have special population of infections who need hepatitis B infection who need treatment. Regarding screening, I believe that we should screen all patients for hepatitis B and HBsAg. If hepatitis B is negative, look for anti-HBs antibody. All those who are negative for hepatitis B antibodies should be vaccinated, because vaccination is cheap, safe, effective, and I'm sure you can today realize the efficacy, utility, and advantage of vaccine when you are badly looking for a vaccination for COVID. If you are still longing for a COVID vaccination, why can't we take vaccination which is freely available, very cheap, very effective, and totally safe? So all of us should go back and check our anti-hepatitis B status. The treatment of hepatitis B virus was started way back in 1992 with interferon injection, so which were giving only a limited relief till we have the advent of newer drugs, lamivudine, adifovir, entecavir, talbibidine, pegylated interferon, TDF, that is tenofovir, disoproxil fumarate, and finally the last drug which came into the market was almost 4 years ago called tenofovir alafenamide, or TAF. There are some new advances in hepatitis B vaccine. Currently, WHO and FDA has approved a new 2-dose vaccine. All of us know that hepatitis B vaccine is to be given traditionally in 3 doses at interval of 0, 1, 6. So WHO and FDA has already recommended a 2-dose vaccine, which has more potent antigen-related stimulation of the antibody production, and it may soon find the light of the day. We should also know how to define our ALT and AST levels, because when you are treating hepatitis B, it is important to know whether the virus is multiplying. 3 things we need to know before treating hepatitis B is there any damage to the liver? Is the virus multiplying, or is there any evidence of immune response? Immune response can be documented by looking at the ALT level. Currently, it is believed that anybody who has, any female who has a ALT of more than 19 and any male who has more than ALT of more than 30 is said to be being abnormal ALT. So the definition of abnormal ALT is normal ALT is 19 in females and 30 in males. And whenever we want to treat hepatitis B, this is what we have to remember. What is the status of ALT? What is the status of the DNA? And do we need any evidence of liver biopsy or fibroscan now to look at the status of the inflammation in the liver? So various societies have given the recommendation of treatment for hepatitis B. So they should be given in patients who have active disease and patients who have immunotolerant disease. That means those who do not have raised ALT but have immune tolerant phase can also be given in subgroup of the settings, and these treatment settings need to be defined. So all those who have active disease, how do we know? You have raised HbSAg level, you have raised DNA levels, you have raised ALT level. These they need to be treated. And those who do not have raised HbSAg level and those who do not have raised ALT can still wait for better drugs to come. ASL, again, same thing in hepatitis B, E antigen positive or negative. Basically, what decides the treatment is whether you have cirrhosis or not, or whether you have active inflammation or not. But look at the way the things have been becoming murkier and more difficult to grasp, and multiple recommendations are coming. But the reason for all this is, at the moment, we have very few drugs which have good action against hepatitis B, unlike hepatitis C. So once the virus enters the cell, it, as I said, it goes and makes a permanent residence within the hepatocytes, and this is called cccDNA. This cccDNA, or covalently close circulated DNA, is the chief culprit which keeps on producing a lot of mRNAs which will produce protein and components of the virus. Virus get assembled again, and this is affected. It's like a car manufacturing unit in Maruti Udyog Limited. You put in the infrastructure, you put in the different components of the car, and you have the assembly of the cars going out. So you need to have drugs which act at multiple levels. At the moment, only antiviral drug which we have acts at a level of RNA polymerase inhibition. So that is the reason we have inadequate drugs. So this is the future of hepatitis B drugs, where we'll be having action of the drug at multiple levels. We can block the entry of the virus into hepatocytes. We can prevent the disruption of the RNA before it enters into the nucleus. Once within the nucleus, you can tend to degrade the cccDNA. Once the DNA has been degraded, you can prevent the replication of the virus with the currently available nucleoside inhibitors. And finally, once the virus is getting assembled, you can use various drugs to stop the assembly of the virus so that the complete virus does not come out. So there is a list of the drugs which are coming into the market. But unfortunately, over the next 5 years, we may not see any of those drugs on our desktops for the use in patients with hepatitis B. What is available today is 2 types of therapy: interferon therapy and oral drugs. Interferon therapy, for all practical purposes, we are hardly using, because it is useful only in genotype A type of hepatitis B, which is very uncommon in North India at least. So what we have to bank upon is the oral drugs, and 3 drugs which should be used today are entecavir, tenofovir alafenamide, tenofovir disoproxil fumarate, and these are the major drugs. Interferon, as I said, gives you short-term therapy, definitive therapy, with clearance of hepatitis B surface antigen in some percentage of the patient. But problem is, there are very few candidates who are eligible to be treated with pegylated interferon. So you are left with only 3 oral drugs for management of hepatitis B. Mind you, we have no reason to be using drugs like lamivudine, drugs like adifovir, and drugs like telbivudine. These are the drugs which have a low genetic resistance. They produce a lot of immense problem in treatment of hepatitis B, and they are down and outrightly out. So what do we have today? We have TAF, and these drugs should not be given. Please remember that if you're using edifovir, lamivudine, and talbivudine, you're not doing a good service to hepatitis B patients today. So you're left with 3 drugs, tenofovir, TAF, and entecavir. The difference between TDF and TAF is that TDF in the dose of 300 milligram has the same efficacy as a TAF with a 25 milligram. That is 1/12 the dose. Advantage of using TAF over TDF is that you're giving much smaller dose in a patient who needs almost lifelong therapy. This is because of the development of a new drug delivery system in which you tend to deliver the drug directly into the hepatocytes, thereby decreasing the excretion of the drug into the kidneys and decreasing the toxicity which is associated with TDF in the form of Fanconi syndrome and osteomalacia. We published our guidelines for management of hepatitis B in India. So we had this position statement, and this is available for reference from Indian National Association of Study of the Liver Disease. Let's talk of some practical situation. 27-year-old young man, E antigen positive, chronic hepatitis B, ALT is hardly any elevation, no inflammation, no activity. So this is the subgroup of the patient who does not require any treatment. Look at this middle-aged lady who is HBe antigen negative, raised ALT, HBV DNA which is high, but she has no other comorbidities. So this is a subgroup of the patient because ALT is raised, you have a DNA high, so you need to give some sort of therapy. So old people, more than 30 years, not old, middle-aged people and old people who are having replicative virus and who have raised ALT certainly do need antiviral therapy. And as I said, today you have to choose either tenofovir, preferably TDF or entecavir. How do we choose between the two? So we have good guidelines how to choose between the two. If the patient is pregnant, then you cannot give entecavir because it is a category C drug. The drug of choice is TDF in patients who are pregnant because this is a category B drug. In a patient who has kidney disease, chronic kidney disease, we prefer a drug which does not have renal excretion. Now look at this. A small dose of TAF is much better than entecavir and TDF because most of the drugs otherwise will have some effect. So if the patient has a bony disease or if the patient has renal disease, this is what we do. So when we are treating patients of hepatitis B, look at 2 factors: age, presence and absence of the bone or the renal disease. In patients, when we prefer TAF over entecavir is in patients who have previously been treated with entecavir and who have a co-infection with hepatitis HIV virus infection. In that group, tenofovir is a better drug than entecavir because entecavir does not have an anti-HIV infection. And when do we prioritize entecavir over TAF? If the expense is a cost or the dosing has to be adjusted as per the creatinine clearance. Now, cost is not a big issue. In fact, now TAF is cheaper than entecavir. So we have new good guidelines which have recently been published in patients with hepatitis B, both in the pre and the post-transplantation setting. And these very clearly show that even in patients who have a concomitant HIV infection, the treatment of choice has to be a tenofovir-based therapy, which has both antiviral drug, anti-hepatitis B action, as well as action against hepatitis HIV infection. So you have a co-infection with hepatitis B virus infection and HIV, the drug of choice for hepatitis B is tenofovir. At times, you may have a co-infection of hepatitis B and hepatitis C. In fact, it has been shown now, since hepatitis C is totally curable these days, if you tend to give hepatitis C viral therapy, at times there may be reactivation of hepatitis B. And most of us now tend to cover up our patients of hepatitis B virus, C virus infection. If they have a concomitant hepatitis B, we tend to cover them up with antiviral therapy against hepatitis B. We also published our recent guidelines from Indian National Association for the Study of the Liver Disease on management of liver disease in pregnancy. These are also available online for your ready reference. And these are something which is important for pediatrician, general physician, practitioner, gastroenterologist, hepatologist, and obstetrician to understand. Pregnant women with immune active hepatitis should be treated as per the recommendation of the non-pregnant women. That means if ALT is elevated or if the patient has raised DNA more than 2 lakh international units per ml. This is the subgroup of the women who are likely to benefit from. TDF is the preferred drug because it is a high potency drug. It has a high barrier to resistance. Infants born to HBsAg positive mother should be receiving both immunoprophylaxis in the form of HBV vaccination as well as hepatitis B immune globulin as per the WHO and the CDC recommendation. Breastfeeding is not contraindicated in women who are receiving nucleic acid therapy. At times, patient may be on immunosuppressive drugs, and this is the time hepatitis B virus can get flared up because of the antiviral act, because it is immunosuppressive activities. So what we recommend is that you look for HBsAg and anti-HBC positivity in all patients undergoing chemotherapy. And those who do not have high levels of anti-HBs antibody and have high levels of HBsAg, they need to be covered a month prior and 6 to 12 months after immunosuppressive therapy with a potent antiviral anti-hepatitis B drugs like entecavir, TAF, or tenofovir to prevent the reactivation of the virus. In patients who are on dialysis and renal diseases, as I said, we have to tailor the doses of TDF as well as tenofovir, whereas if with TAF, you can continue the same dose till a creatinine clearance of about 15 ml per minute. Again, we published our guidelines on management of hepatitis B in patient on chemotherapy and those who are taking immunosuppressants, including drugs for rheumatoid arthritis or corticosteroids. These are again available for ready reference in the recently published articles. At times, you may have to give urgent antiviral therapy against hepatitis B because of the extrahepatic manifestation. And these include vasculitis, purpura, polyarteritis nodosa, arthralgia, peripheral neuropathy, and HBV-related glomerulonephritis. Drug of choice in these conditions is oral nucleoside drugs. Pegylated interferon should not be given, and it is something which is known to precipitate autoimmune response. And finally, because we do not have drugs which act at multiple levels, like at the level of entry, at the level of disintegration of the rcDNA or disintegration of the cccDNA, we have a drug which acts only at the fag end of the cycle, and hence we have poor results in eradication of hepatitis B as against the Nobel Prize winning treatment of hepatitis C, which has recently been acknowledged all over the world. So what we need to have, ladies and gentlemen, drugs which not only try to kill the virus, but also stimulate the immune response to kill the infected hepatocytes so that the patients are going to get cure from hepatitis B. So large number of the drugs are in the pipeline. We may see some of them, they may see the light of the tunnel after about 5 to 10 years. As of now, we do not have drugs other than maybe TAF and entecavir for treatment of hepatitis B. To sum up, ladies and gentlemen, treatment guidelines recommend treatment of hepatitis B only in patients who have elevated DNA, ALT, and evidence of damage to the liver. So if you have some injury to the liver, DNA is elevated, ALT elevated, all these patients should be treated. Treatment should be restricted only to 3 drugs: entecavir, TDF, and TAF. TAF is a preferred drug because it is almost giving you 1/12 the dose of what TDF gives. Most of the patients will require a lifelong therapy. Pegylated interferon can be given in subgroup of the patient who have genotype A, some of which is very uncommon in India, at least in northern India. And nucleoside analog, like all these drugs, should be given, that should be taken in all patients who have comorbidities and who are planning pregnancy. Lamivudine, telbivudine, and edifovir should not be used. A new 2-dose vaccine is now available, possibly will be coming to India soon, and you may not need a 3-dose vaccination for hepatitis B. There has been a repeat revision of the definition of the ALT, again to reiterate that 30 for males and 19 for females is the upper limit of ALT in the current scenario. Tenofovir alafenamide is included as the preferred drug for treatment of hepatitis B today. Depending upon whether you have a renal or bone disease, you can choose between entecavir and TDF. In patients who have a concomitant HCV infection, please monitor for hepatitis B. There may be reactivation of hepatitis B. And if the patient has been on chemotherapy, patient may have reactivation of hepatitis B. Tenofovir is the drug of choice for treatment of pregnant women in 3rd trimester of the pregnancy, especially if the HPV DNA is more than 2 lakh international units. Viral hepatitis A today is characterized by A, B, C, D, E, F, and recently a TT virus. 2 viruses are transmitted by the fecal-oral route, hepatitis A and D. 3 viruses, B, C, and an incomplete virus called Delta virus are transmitted by the parenteral route. Diagnosis is made by serological analysis, which is quick and easy. Hepatitis A virus has a poor outcome in adults. Hepatitis E virus has a poor outcome in pregnant females. Less than 1% of all acute viral hepatitis lead to fulminant hepatic failure, and hence most of the patients with acute viral hepatitis do not need antiviral drug. Treatment of acute viral hepatitis is only supportive. In patient with HCV, you have direct acting antiviral drugs, which gives you almost 100% efficacy these days. Treatment of chronic hepatitis is the best way of curing the disease, and luckily we have good vaccine available for hepatitis A, B, and recently hepatitis E vaccine is also likely to come to the front fore. With that, I'll end up my talk, thanking you for your patient listening, and hand over the floor back to my moderators and the chairpersons.
Mute your voice is mute. Tapan bhai.
Thank you, Dr. Arora, sir. It was a fantastic session.
Sir, excellent talk, thorough information regarding the various hepatitis, particularly hepatitis B. At what, suppose we are giving antiviral drug for the prevention of transmission from mother to child in case of hepatitis B, up to what duration you should give the treatment?
Yeah, you see, the question is, can you come a bit closer to the mic? Your voice is not as robust.
Yeah, up to what duration, once you are starting any antiviral drug, suppose TD of in a pregnant lady for prevention of mother to child,
Yes.
not for herself,
Yeah.
then up to what duration you will give and then stop?
Yeah.
And what
You see,
precaution you will take?
recommendations are that only those pregnant women who have either E antigen positivity or DNA of more than 2 lakh international unit, starting in the third trimester of the pregnancy, and then continuing it at least for next 3 months, because pregnancy by default is an immunosuppressed state. Once there is a postpartum period, there is likely to be immune reactivation. You can have a virus coming back because of the immune reaction. So if you continue to suppress the virus for another 3 months, then that is preferable. My own policy is that if the patient is antigen positive, DNA is high, then why not continue this drug even longer? But recommendations are after 3 months. If you're not willing, you can stop it, but I'll prefer to continue it longer.
Then how many cases, sir, you seen that reactivation of hepatitis B after stopping the drug?
Yeah,
This
you see, in fact, my policy is you see, why do we stop it? After that, again, you switch back to the same type of indications for treatment of hepatitis B as would happen in a non-pregnant male or a non-pregnant female. So you go back to the same stage. But I believe that once you have crossed the age of 30 years, once you have a long-standing infection, if there is evidence of replication, why not suppress it for a long period of time? I usually tend not to stop it, because tomorrow if you have a drug which is going to get cure of the virus, like what happened in hepatitis C, tell me, will you not give it? It is just because the drugs only suppress the virus, do not cure it, we tend to stop it. We're just waiting for new drugs to come. I'll at least continue the drug.
Then, sir, regarding the vaccination,
Yes.
but is there any change in the immunosuppressed patient and immunocompetent patient, the doses scheduled and the dose?
Yes. In fact, in patients who, especially patients who are on dialysis, and especially with patients who are immunocompromised. After all, what does a vaccination mean? That means you are giving an attenuated antigen. You are letting the immune system of the body respond by generating antibodies against a specific antigen, which is known to produce a protective antibody. So in patients who by default have immunocompromised state, that means those with lymphomas or those with chronic kidney disease, you have to give double the dose, that is from 1 ml to 2 ml, that is 10 microgram to 20 microgram, and then you have to give them in a schedule of 4 doses, 0, 1, 2, 6. Traditionally, we give 0, 1, 2. 0, 1, 6 is traditional we give, otherwise we give 0, 1, 2, 6, 4 doses in double the dose. And
So
even
would
then,
you,
the total response rate is not more than 50 to 60%.
so would you like to monitor by doing a anti-HBs antibody titer in this situation, and up to what level, what titer you
Yes.
will?
And anything, and in a normal immunocompetent person, any titer of more than 10 is enough. Whereas in a patient who is immunocompromised, higher the titer up to 100 certainly is better. But then we should also understand the constraints. In immunocompromised person, you are not likely to have high titer. But if you are able to maintain high titers beyond 100, that is more recommended.
Sir, one question from Dr. Milinja. Is there any role of titrating the HBs antigen in treatment and prognosis?
Yeah. You see, in fact, if you look at the way HBsAg is produced, it is produced from the three different sources. It is produced from the cccDNA. It is produced from the incoming virions, which are again entering the hepatocytes, and it is also produced from the integrated DNA. So there are three sources of HBsAg production. So what antiviral drugs they do is they are only suppressing the formation of the DNA. So HBsAg quantitative will have no effect with the currently available medication. The only reason why we still keep doing it, it is useful in patients for interferon therapy, in which if you kill the virus, this level will go down. But if you monitor these levels, these are the patients who are like to tell you how long the therapy will continue. Any patient who has a declining level of HBsAg is more likely to have a spontaneous clearance than a person who continues to have either stable or increasing level, even though
So,
it has no direct one-to-one relationship with the orally available nucleoside analogs.
so in your practice, how many percentage of patients have lost the HBsAg in oral anti drugs?
I think my own impression is, because I, in fact, prefer to treat most of the patient with antiviral drugs. About 2 to 5% of my patient, they tend to lose the HBsAg antigen. And this is the subgroup of the patient who have immune reactivation at some point of the time,
At some point,
not
yes.
because of the drugs alone.
Yes. So, question from Dr. Narendra Patel. Uh, how do we manage hepatitis B with COVID-19 infection? Is there any difference or same?
Now there are two noxious agents which are affecting the liver. One is a COVID, and second is a hepatitis B virus infection. In fact, at least I sincerely believe, till you have nothing else, a drug like TAF is absolutely safe. It is given in a minuscule dose of 25 milligram, has a potent effect, and does not have any resistance. So I'll tend to cover up almost all my patients beyond the age of 30 years with antiviral drugs, including TAF. The treatment of hepatitis B in patients with COVID is no different than if they do not have COVID infection, except you will have more toxicity of the liver because there is an indirect effect of the COVID virus infection onto the liver, even though it is not directly cytopathic virus. It causes the effect by immune response.
So, one another question from Dr. Tarun. If a pregnant lady is HBeAg positive, but HBV DNA is less than 2 lakh per ml, can we ask the patient to convince that she does not need treatment?
No, no.
ALT is 50,
See,
60.
so it has to be both. It's very unlikely that HBe antigen will be negative and DNA will be high. If HBe antigen is negative, I'll always treat the patient. Then you forget about DNA load. So DNA is more important than HBe antigen. HBe antigen positivity has the maximum chance of transmission of the infection to the baby. So either HBe antigen positive alone, that is good enough for you to treat. So what do you lose? Because it has been absolutely clearly shown that there is no toxicity of tenofovir in the intrapartum period. There is a good data which has been available from HIV studies. In
Yes, sir.
HIV, all pregnant women are given this heart
Yes, sir.
therapy. This is totally
Yes,
safe. So
yes,
I'll
sir.
not bother about DNA if HBe antigen positive. That is the most definitive marker of infectivity and replication. So I'll not bother about DNA.
So, one another question from Milinja. Asymptomatic normal LFT, negative HBAG and low HBV DNA, but high HBsAg to treat or not? If yes, then how?
I'll go by two more parameters. I'll go for fibroscan value. I'll go for weight of the patient, presence or absence of NAFLD, concomitant alcohol intake, and fibroscan. So if the patient has dyslipidemia, metabolic syndrome, non-alcoholic fatty liver disease, age more than 35 years, I like to give antiviral drug.
Okay, sir. Then another question. That is on the liver transplant. When to stop the HBV treatment? Any criteria?
Yeah, HBsAg treatment should be stopped only if you have HBsAg cleared and anti-HBs antibodies are present. That in my practice occurs in 2 to 5% of the patient. That too only subgroup of the patient who during the course of the time have immune reactivation, in which the immune system gets enough of boosting coupled with antiviral drug to get rid of the virus. I can take the credit, but credit, see, it has to come from within the immune system which gets reactivated. So only if anti-HBs and antibody is positive will I stop the treatment.
Sir, we usually in a HIV co-infected patient, any HBS, I mean any HBV infected patient, we start drugs right now. It's a whether whatever the CD4 count is there, whatever the value is there. The question from Dr. Smith Kumar: in HBV HCV co-infected patient, should be treated simultaneously or HCV after HBV?
Oh, no. See, there is no question. HCV is a definitive therapy of 3 months. A combination of sofosbuvir and valpetasvir will give you 95 to 98% cure rate. So there is no question of no question of delaying treatment one against other. The only problem of treating HCV alone in presence of HBsAg is, as HBV has an inhibitory effect on HBV replication, if you get rid of hepatitis C, you're likely to have a flare of hepatitis B. And hence, if HBsAg is positive, DNA is positive, I like to cover my patient with tenofovir during treatment with antiviral therapy. If it is such a simple drug, rather than monitoring, why not cover it up?
So another question from Dr. Mustafa: marriage over HBsAg positive partner with a normal partner. Your take and advice.
Marriage or no marriage? First of all, you see, as a physician, obviously it's not a stigma. It's not a something which patient should not get married. Why shouldn't they get married? After all, if male is positive, female should get vaccinated. She will never have the infection because female has to bear the child, not the male. And if the female is positive and male is negative, male should get vaccination because if the spouse which is not infected gets antibody positivity with vaccination, which has the efficacy to the tune of 95%, you can lead a practically normal life. There is a question of denying the marriage.
Sir, another question from Dr. Smith Kumar: HCV, HBV positive doctor, what viral load safe limit to perform the operation legally?
See, there are guidelines in US and in the UK. We have no guidelines in India. In India, in US, the patient may have a right to know whether me as a surgeon, am I positive for hepatitis C? What is my level? Am I likely to be a source of infection to my patient? They have a legal right to know that. In US, what they see is, in UK, they have a guideline that if HPSAG positive surgeon is on antiviral drug and if his DNA is less than 1000, he can jolly well operate. But with the currently available antiviral therapy, you will have a practically nil virus. And in hepatitis C, now the scenario is totally different. Anybody who is C, just take a pill daily for 3 months and you're totally cured. So there is no problem of continuing to have surgical intervention even in presence of active viral infection.
So one another question is, you have nicely covered how to differentiate from from chronic hepatitis B and whether the treatment is required in acute hepatitis B. Yours says that no treatment is required for acute viral hepatitis B. One another question, sir: how to is there any role of ribavirin in hepatitis E virus and hepatitis A virus?
You see, hepatitis E virus, we conducted a study at Sir Gangaram Hospital. We took the samples of hepatitis E virus in 100 consecutive patients who were suffering from acute hepatitis E, as documented by IgM anti-HEV antibody. And only 5 of the 100 samples had HEV RNA positivity. That means by the time you have icteric hepatitis and hepatitis E, for which patient requires hospitalization, the virus is not multiplying anymore, or the level is too low. So in 5 patients, we gave them ribavirin therapy. And most of the time, by the time patient comes to you clinically, HEV RNA is not detectable. And once it is not detectable, there is no justification of giving ribavirin. In hepatitis A, we have never used it.
So I think majority of question has been covered by very nicely you. Your presentation was excellent. I think now I just hand over to the chairperson.
Sir, one question, sir. In acute viral hepatitis, definitely we don't give it, but in acute viral hepatitis, it gradually turns into failure. I think there is an indication for treatment.
Yes.
You can highlight on that, sir.
Yeah, I think it is an important question, Yogesh, you have raised. There is something called acute hepatitis B versus reactivation of hepatitis B. In fact, there are hepatologists in India who do not believe there is something called acute hepatitis B. They believe almost all hepatitis which is presenting you acutely is because of the reactivation of the virus. And it is not easy to distinguish between the two. So at times when the patient is, you are losing the ground in terms of, complication occurring in terms of ascites or rising PT, INR, there's no harm in giving antiviral drugs because the distinction between acute B versus reactivation of underlying B is not easy. And one way of distinguish between the two is you can look at the fibroscan, you can look at an ultrasonography to look at the contours. There are people who tend to do the level of IgM antibodies, core level, and subfractionation of IgM core to distinguish between the two. In a clinical situation, if there is a problem and if there is a suspicion of underlying chronicity, do start them on antiviral. I agree with you.
So, if you allow one more question, sir.
Yes.
What is the significance of core antibodies?
Core antibodies are of two types. One is an IgM core antibody, and second is a total core antibody or IgG core antibody. IgM core antibody is an indication of acute infection. So it would indicate that you have recently acquired infection, or even if you have had acquired the infection in the past, there is a reactivation of the virus. So it only indicates acuity of the infection. Whereas if you have total antibody, that means you may have had infection in the past. So distinguish in a patient with acute presentation of raised ALT, say in thousands, to say this is because of hepatitis B, you need to have core antibody. Classical example is if you are incidentally hepatitis B carrier, you are simply carrying the virus in the blood and then you have hepatitis A superimposed. Now in that situation, IgM antibody against hepatitis A will be positive, but core will be negative. But if IgM A is negative, E is negative, core is positive, then possibly this is hepatitis B. So, and that is one advantage. Second is you have a window period in which SBSAG is not detectable and IgM antibody, HBsAg may have gone away, antibody has not come. In between, there is a small window period in which you can pick up IgM antibody against hepatitis B core antigen to say that this is an acute infection. That is another advantage of doing IgM core.
So there is one more interesting question that in a child with hepatitis B or C, what age and which medicines are safe to treat?
In fact, various drugs have been shown to be safe at various ages. Interferon has been shown to be safe beyond the age of 2 years, whereas drugs like tenofovir, entecavir, and TDF have been shown to be safe beyond the age of 8 to 9 years. But it's just a question of time. With altered pharmacokinetics, even younger people can be given. As of now, interferon beyond the age of 2 years, entecavir or TDF beyond the age of 9 years.
So one last question, if you allow us.
Yes.
Dr. Tarun wants to know, do we routinely check IgG before vaccinating for hepatitis A or E?
There is, in fact, at the moment, there is no vaccine available for hepatitis E. There was a very good publication from a Chinese company's study in Nepal, which had shown about 85% protective efficacy. It was published in Lancet about 10 years ago. But since this is a disease of the poor country like ours, so nobody took interest. Companies like Pfizer and other, these Western companies, they didn't take any interest in it. And hence we do not have it in the market as yet. Regarding hepatitis A vaccination, since the vaccine is costly, I'll prefer to get an antibody done because getting an antibody done is cheaper. And if Yogesh, if you see your own practice, 95% of adults in India, if you look for their IgG against hepatitis A, will be positive. Hence, you don't need a vaccination. Because the cost of the vaccine for hepatitis A is much more than the cost of testing, whereas in hepatitis B, it's the other way around.
Dr. Vipul, Dr. Tapansha, any further questions? You are mute. Dr. Vipul and Dr. Tapan, you are mute.
I think sir has covered completely. Any question from Tapan bhai?
Sir, you are mute, sir.
So one last question, if you allow, sir.
Yes, sir.
If someone is cured from hepatitis C virus, how long should they get tested for HCV iron on a yearly basis?
You see, it depends on, this is something called sustained virological response, or SVR. SVR by definition means once you have cleared the virus. So this is today defined as absence of HCV RNA in the blood for 3 months after stopping the therapy. This is called sustained virological response. And once you have a sustained virological response, the chance of having reinfection over the next 10 years is only 6% because of the recrudescence of infection. It is believed that some of the virus may be hiding in the peripheral lymphocytes. That is the explanation. Antibody will remain positive always.
Yeah.
And HCV RNA was negative. If you can take, if the patient is non-cirrhotic, you can have 1 or 2 more readings. After that, you don't need it regularly. But if the patient has cirrhosis of the liver, so this is a subgroup of the patient who needs to be followed up. A lot of patients ultimately develop complication of compensated cirrhosis, including HCC, even after clearance of the virus. Because by the time you have cleared the virus, they have already caused enough damage to cause cirrhosis of the liver.
Thank you. Thank you.
Thank you, Dr. Anil Arora. It was a very nice and lucid presentation. Sir, if moderators and chairpersons allow, can we close the session?
Yeah,
Sure.
sure. Thank you.
Thank you so much, Dr. Anil Arora. And at the end, I would like to thank all organizations who have contributed today. And I would like to thank my mentor and guru, Dr. Mahesh Goenka, who is also course director for this academic event called Advanced Gastro Summit. At the end, I thank Dr. Anil Arora. It was an honor and very much pleasure. You took time, especially 1 hour, sir, during a weekday to contribute academically. Thank you, sir. Thank you so much.
Thank you. Thank you and bye-bye.
Good night, people. Good night, Tapan.
Good night. Good night.